we are empathetic people. And how can you provide your highest quality of care the entire time when you're worried about them being in pain? I've been doing this for a long time, and it still happens where I'm like, okay, let's go ahead. I want you to take some nice deep breaths. And that's also myself, like reminding myself that I need to do that. And, just remembering that all of the education that you have behind you and everything that you already know, just keep reminding yourself, you know what you're doing, you know where to go, you know how to handle the situations.
If the hygienist is the one delivering local, it's very, very important that, you're kind of paving the way of how this visit's gonna go. So being very secure, confident, and making that patient comfortable can do a lot for their experience, but also for the doctor treating.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 317. My name is Andrew. And we have a great show for you. And I apologize. I am still not over this cold. My voice is still a little bit scratchy, but it sounds a lot better than it did last week. So this episode is your student roundtable for the month, and I'm joined by Kelley, who you might remember was on a couple of our episodes around this time last year, and also Tina Clark, aka Teacher Tina, who has been on the show several times as well. Of course, while these are roundtables that are geared towards students and new grads, I think that we can all learn something here, because as I was sourcing the questions from this, they all came out of those dental forums that we're all a part of. It's the stuff that we're seeing all the time. And we kind of jumped around a little bit with some of the questions for them, but I really try to focus on either local anesthesia questions or pediatric questions or both. And so we'll hear from them in just a few minutes. But wow, everyone, just wow. I want to thank you all for the wonderful messages that we got over the weekend. It was very thoughtful, and I want to let you know how great it feels to have that kind of response to the news. And if you've not really had a chance to see our social media yet, or you didn't get a chance to listen to last Friday's episode, either pause it now and go back and listen to it, or maybe find a chair. You might want to be sitting down for this. Michelle is stepping away from the podcast starting this month. You're going to hear her voice on a couple of more episodes, as she's already had some interviews that she pre-recorded. And it's very big news. And we, of course, are going through all sorts of mixed emotions over here. Lots of questions got asked that I don't know if I have the answers to right now. But I can say this, the show is going to continue. We will have a series of guest co-hosts, probably, I think. And we're going to still have some amazing people coming on the shows talking about all things dentistry. So that stuff, that particular part of it's not going to go away. There are definitely some things I just don't know the answer to quite yet. I'll try and keep you updated as much as I can throughout this whole process. But I would probably say I wouldn't expect any major changes like new intros or music or anything until probably March or April of this year. So yeah, we're definitely not in any hurry to get things changed over. In other news, I will be podcasting later this month in Chicago at the Midwinter meeting. So if you're going, please shoot me a message so we can try and meet up. And like we mentioned a couple episodes back, the podcast will be doing live interviews from the Hinman meeting in Atlanta, which runs March 17th to March 19th. And I'm really excited about this concept that they're doing, and also very grateful that they invited us. They have a dedicated podcast lounge that they're going to be setting up, and it's booth number 757. For us, our time slot is Thursday, March 17th from 9:30 a.m. to 1 p.m. And then also, just as a side note here, our friends Teresa Duncan and Kevin Henry will also be at the same booth recording their Chew on This podcast right after us. So if you're at the meeting, be sure to swing by and say hello to us, say hello to them. If you want to record live with me at the show, please send me an email, andrew@ataleoftwohygienist.com. I am scheduling some people right now. There's also going to be a lot of great speakers lined up at Hinman. So if you want to see who's all going to be there, you want to get registered, make sure you head over to hinman.org, and hopefully we'll see you guys there. Next week, we have another great show scheduled. It'll be the second to last interview that Michelle will be on. and it's with a fan favorite, Sarah Hornsby. Sarah is back to talk to us and deliver some more of that insightful knowledge and thoughts and tips for our patients that she has. So be sure to click that subscribe button so you don't miss out on that. I think that's it for me. So, actually, wait, I forgot one more thing. This is a part 1 of 2 with the second part coming out in March. So make sure you come back for that one. Okay, so that's it. Enjoy this episode with Kelley and Tina. Welcome, everyone, to the interview portion of the show. I am joined today by Kelley and Tina. Both are returning to the show. Welcome back, everyone. So let's do this. So for the listeners that maybe, because Tina, you were actually just on, not with us, but with Hygiene Edge on with us. So I'm probably 4 episodes ago, or probably by the time this airs, it'll probably be like 8 episodes. But
about that, yeah.
But if you haven't gone back and listened to those episodes, and last year Kelley and I did several things, would you both mind reintroducing yourself to the audience? Tell them a little bit about who you are and what you do.
So my name is Tina Clark, and I've been a dental hygienist for over 20 years and a dental hygiene educator for about 15. And local anesthesia quickly became my passion. And I've taught it to students and to dental hygienists all around. And I really love teaching it. I love talking about it. And I provide continuing education courses on it. And anytime someone says, hey, can we have a question about anesthesia? I'm like, oh, please let me help you. Let me talk.
Love it.
And my name is Kelley Qualis. I have been in the dental field since 1996 as an assistant and a dental hygienist for 12 years. And I left clinical practice a few years ago and opened my own oral facial myofunctional therapy practice. And I mainly worked in pediatric dentistry.
So the base of this show, when we talked a couple weeks back, was, okay, hey, we're going to do a round table on, pediatric, local anesthesia. Fantastic. And so I started coming up with questions, and I was like, I feel like what I'm interested in might not be what the world is interested in. So I went to social media, as we do, and I started going down this rabbit hole. And this rabbit hole, how when you're scrolling on TikTok or whatever, it takes you to different places. I'm like, holy crap, the people are in a different place than I am. So I apologize about switching up the format, listeners, and for the both of you. I know you're both very qualified to answer these questions, but all I did was pull a bunch of questions, just random questions on local anesthesia. Several of them are still about pediatrics, but it might not still have the same feel. So hopefully that's okay with the both of you.
Yeah.
Let's do it.
Okay, so also, before I get into this, have either of you heard about Georgia?
Yes, I heard that they will be coming up on the next group. So was it North Carolina, and now Georgia's coming up, right?
Yeah. So one of our friends, Misty, she's on the board of dentistry there in Georgia, and they've been working really hard to get local anesthesia passed in Georgia. And so it's coming. It's it's been approved. I think they still have some things that they have to work out, but it's just happened in January of 2022. It's so exciting. So
what a way to start the new year.
Oh my gosh. I'm hoping actually maybe have her on at we're gonna go to Hinman and see if she'll record with us and talk about that process. Cause I bet that's such a thing. I think a lot of us, I think Tina, on your episode of the Hygiene Edge, you guys talked about kind of the history of local anesthesia, and, Washington had it. And then I think they were saying in Utah was 1983. It's a lot of us came into it where we already kind of had it as a luxury. It'd be really nice to see the process for a state that has this is all brand new, and what do the hygienists really think? Are they really excited about that? Or is it I don't really want to do that?
Yeah.
So
it's the birthing process.
It's painful to go through, but a great
reward.
Outcome?
A great end.
Is that okay.
Yeah.
Having not gone through it exactly myself, I was just trying to guess there.
It's worth it.
So let's do a warm up question. Okay. So this is a couple. The first ones are pretty easy questions. So the first one is, someone asked, did your board patient require local anesthesia? And also tell me your thoughts on that.
Yeah. So my clinical board patient for my clinical exam, yes, I had to do that. And, that was over 20 years ago. And so all I remember is I did the lower left quad and that I passed. The anesthesia part of it for my board exam, that wasn't such a memorable part of it. The for the clinical board, now my anesthesia board exam was very memorable for me, but for the clinical part, it wasn't. That didn't faze me at all.
Mm-hmm.
Yeah, my patient did, and I also had to use. There was a language barrier. Now I can speak Spanish moderately, but to explain and prepare the local anesthesia for a patient that had never had a dental cleaning in her life. That I do have a very vivid memory of that, and just making sure she was comfortable and knew what was coming, because I wanted her to be as comfortable as she could during the process. So I think we all come from a place of wanting the best for our patients. So talking through that in my clinical boards was definitely a learning experience.
It's brave of you to take someone to your boards that has never had any dental work done ever.
Yes.
Like that's a risky move there, friend.
I passed.
So so a lot of right, this is like a student roundtable, right? It's very focused on the students. Would you recommend that they get their board patient numb?
Yes.
For their clinical part?
Absolutely.
Yes. Oh, absolutely. Hands down. Because, we are empathetic people. And how can you provide your highest quality of care the entire time when you're worried about them being in pain, plus all of the pressure that you have on that exam already? It's like, set yourself up for the absolute best success you can, and just try to eliminate all the different obstacles that are going to come your way, which would be your patient being in pain and jumping and moving and making you pause and stop all the time. So yes, do it.
Absolutely. If they're comfortable and they can go to a place where they're just relaxed in the chair, guess what? You're not going to have that other layer on top of what's already a stressful situation. It's just going to make things a little easier and a little better for you. So absolutely. And they're comfortable too. So
yeah, 100% agree. For all those reasons. It's one of those things when, because I'm an examiner for board exams, I've talked about this on the podcast several times of like, look, there's several things that you need to do. And this, you have to get your patient numb and also have brand new and or sharp instruments. Like those are like the musts. And then everything else is like a really, 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 really nice thing to have. Okay. So this next question, it was kind of in response to a larger topic question. I did a lot of scrolling. It was a fascinating adventure. One of the comments that someone said though, in response to the main topic was, it was more of a question: is pediatric local anesthesia really that much different than adult local anesthesia? Because they're trying to minimize the person's concerns from the original post and say like it's all the same. But Kelley, is that true?
No. I mean, no and yes. That's a loaded question. But it's really behavior management. I think that's the hugest difference. And being so secure and confident in your practice, in the deliverance of local anesthesia, because, like we said, we want them to be comfortable, but you also have to add another layer on top of that of making sure that they're safe, making sure their parents are not, breathing down your neck and, creating an unsafe environment for you. So definitely the technique is very similar, but the, consideration of the patient and the delivery is different.
Yeah, absolutely. I agree. It's patient management at its finest.
Yes.
For sure.
Yes.
Yeah. I mean, and I would also there's a little bit of anatomical variance, but when you have someone with large jaw, small jaw, there's still a lot of the same landmarks.
For sure.
But the amounts that you're giving, I think that for me, I worked in pediatrics just a little bit, and it just felt so different, so different, and from a behavior standpoint, but also just from a technical standpoint. I feel like you have to be a little bit more precise in some things, and then also not precise in other things. So later on, I'll have another question about infiltrations and stuff that has to go with pediatrics. Okay, the third question. Nope, second question. The first one's a warm up. Okay. Please describe the term block versus infiltration, and are maxillary blocks much different than infiltrations?
Oh, I love this question. I love it. Okay, so I actually have a whole write-up on my blog about this because I get asked this question all the time. So a block means that you're giving the injection, the anesthetic, further away from the site that you want to have numb. And it also means you're getting multiple structures numb at one time. So we already know, like the classic, as you said, like the mandibular, the IA, the Gaugates, those are classic blocks. The maxillary blocks there are some. It's the infraorbital, and the PSA is kind of, depending on who you talk to, it could be considered a block or a field, like a field block. So a nerve block or a field block. With an infiltration, the point is that you're only getting a small, technically only supposed to be getting one structure at a time. So technically a PDL or a papillary injection are infiltrations. But if we're trying to only anesthetize one tooth, that's a supraperiosteal, which is still considered kind of a field regional block. It's very convoluted, but yes, we use the word infiltration all the time when we're just thinking about one tooth, right? But, if we look at the true definitions, that's how it is. But infiltration, you're looking at one particular structure, smaller amount of tissue or structures being numb.
Have you ever thought of that as being intention based versus like actual anatomy? So for instance, this is where my brain is going from. In school, they say, okay, Andrew, I need you to get number 13 numb, do an infiltration above number 13. Now, my intention is an infiltration just to get number 13 numb, but we know that it's going to diffuse, and you're going to have some mesial and distal anesthesia or a field area, whatever the, I guess, technical term is. Do you think that we're teaching it wrong based on intention versus actually what's happening?
Yes, I do. I think because, there are those three different ones. You have your nerve block, your field block, and then your infiltration. When you are doing that, that is a field. You have a whole wide area of doing it. So I think that if we try to change it now, it would be like, what's the point? Because it's so ingrained in who we are as dentistry.
Yeah.
It really is. But, if we want to go technical, if you want to look at the world of anesthesia as the greater world from, general anesthesia, all the people that do it, we're using it incorrectly, but we're dentistry and we like to do things a little different sometimes. So
yes, we do.
So yes, it is. We should be calling it, if you say infiltration and that's what you do, everybody's going to know what you mean.
Yeah.
Okay. Here's a scenario. I'm going into a local anesthesia clinic tomorrow and I'm nervous about my hand shaking too much. What can I do? Similarly, there was another story that I want to read that says, I just received my local anesthesia license a little over a month ago. I did fine during the class. I even did fine a couple of weeks after the completion of the course, but in just the last 2 weeks or so, I suddenly started shaking a lot when giving injections. I'm not sure why. I just lost all confidence in myself. I know I'm overthinking. I just don't like hurting the patients. For some reason, I cannot get past it. I worry so much that I'm going to shake then I shake even more. Oh. I've cut out caffeine. I tried eating better at breakfast and lunch and making sure I wasn't shaking due to low blood sugar. I want to add, I know that to be better, I have to continue giving injections and not avoiding them at all. It sounds like she's answering her own question, just so you know, as we go through this. And so I've numbed plenty of my own patients and even the doctor's patients. I just really want to be better. I want to be more confident. What can I do? And so these two scenarios are very, very similar. It's about the shaking. We see that a lot in dentistry. What can they do?
So in my experience dealing with pediatric patients, definitely you can be nervous, right? So if you know you're going into the room to administer local anesthetic and you have a squirmy wormy in the chair, what had helped me is when I start to deposit, I really focus on my breathing. I make sure that my mouth's closed. I make sure that I'm just thinking about, well, you're also analyzing the situation at the same time, but we can multitask. It's breathing slowly through my nose, inhaling, exhaling, and making sure that I'm focusing on my breathing and making sure I'm calm within myself. taking that moment, because when you're depositing, you want to go as slow as you can, right? And that's a moment that you can check in with yourself. They're not going to see your hand while you're depositing the anesthetic. So, if you can kind of mentally get around that and know that, calm is coming, that's what's helped me in those instances where that's occurred.
Kelley, I agree. I think breathing is huge. It's definitely, from Andrew, from what you were saying, she's already answering her own questions. A lot of it is mindset as well. And so, the breathing, and sometimes even when we talk our patients through breathing, just like take some nice deep breaths. There are so many times where it's like, I've even done this for myself when I have a patient that is super anxious and that they get my anxieties up too. I mean, I've been doing this for a long time and it still happens where I'm like, okay, let's go ahead. I want you to take some nice deep breaths. And that's also myself, like reminding myself that I need to do that. And, just remembering that all of the education that you have behind you and everything that you already know, just keep reminding yourself, you know what you're doing, you know where to go, you know how to handle the situations. And then when the shakes are happening, making sure that you have a nice, strong and stable rest or fulcrum where you're using maybe your thumb of your retraction hand on the barrel to stabilize it. So that way, that will help you feel a little more stable, kind of give yourself a kickstand so you don't feel like you're going to fall all over the place. I think that really helps too.
That's a good one. Oh, yeah, I think body position, right? Like I saw like a video, someone was like chicken winging. Is that what they called it? They're like chicken winging.
Right. Yeah. Yeah. When you can keep your body stable, if you can make yourself feel like you're one with you, the patient, the syringe are all together one, that will keep your shakes down. And then if they move, like you're moving with them, which, right, Kelley, that happens with kiddos.
Well, I was going to say that, I just remembered locking my elbow into my ribs really helped limit, if I was kind of nervous or the patient was giving me anxiety vibes. So locking my elbow into my ribs definitely gave me that extra body fulcrum that helped kind of calm my hand or my arm. So it happens to all of us. That's the other thing too. Don't feel just because you're new in this field that it's just you. It happens to all of us, and we just have to have the tools to pull out to know what to use in those moments.
I think that's a great point too, because I've been doing this for a long time, and both of you, I've taught other hygienists how to do blocks and injections, and I've given so many injections. But my new role, I don't do it nearly as much, and I stepped in just about a couple months ago, and the patient was even already numb, and they just weren't numb enough. And so I'm like, okay, well, they probably missed the block. We're extracting a lower tooth, and I'm like, okay, well, I'm gonna do kind of a little bit different technique. And it had been months since I had probably given an injection, and I started shaking a little bit, and I am super confident. I know exactly what I'm doing, and the patient was already numb, not nervous, perfect, everything. It happens to us all. So don't let it, I'm glad that you said that, because you can't let that kind of stuff get you down, because then you're just gonna go down in your own little thoughts to even worse. So
it's easy to spiral thinking I don't know what I'm doing, but it's just a part of being a human.
Exactly. Yep.
In the first part of the question, they were talking about going to a clinic. So it tells me that they're probably a student. Or did either of you have requirements in school for pediatric injections?
No, sir.
No.
Nope.
No, I didn't either.
Which I think it would be helpful if that were something, where you have a difference in, just like we had case type patients that we had for our requirements. I think that would be super helpful to have that learning experience in the school setting, in a clinical setting.
Did either of you have in school externship situations where you go out in there? See, we didn't have that. Darn it. You guys are so lucky. Lucky ducks. Well, because I was thinking, our doctor was not about to see a child and do any sort of restorative work on a squirmy little 4-year-old. I never would have been able to get that practice, and so, okay. You both doing all right?
Yeah. Well, I was going to say, Andrew, I think that there's some wisdom in the doctor that you worked with, that him knowing his limitations and being able to refer, that like that's a lot of wisdom. I've seen people were like, oh no, we're going to all do it all in house, when they may not have the skill sets to be able to treat that type of patient population. So that was good.
Yeah, great point.
Oh, we got some foreshadowing going on. We got a question about that a little bit later on. Okay. All right. Let's see. So this was also in response to a question. I think it's a doctor question. It said, I'm a doctor and never give Pedo blocks, only buccal infiltration with Septicaine. And so my question to you both is this normal? Is this normal habit? Is this normal what people do even for like lower blocks?
We gave blocks all day, every day, multiple times a day in pediatric patients, or I did. And it's definitely something that you want to be able to provide for the comfort level of that patient. Because if you're doing nerve treatment, if you're doing crowns, if you're extracting a primary tooth, and you're gonna need the block anesthesia, because that's going to be more effective. So yes, it's definitely something that you want to be able to provide and have the skill set to do so in pediatrics.
I guess I should probably qualify, Tina, before you go, that I think when they say infiltration, I think it's more that field block we were talking about earlier. I think it's I'm trying to extract number T, so I'm going to inject, directly apical to like where T roots would be. Have you heard of this practice happening out there in the world? You have, Tina?
Yeah, absolutely. Especially with Septicaine, because Septicaine is designed to really penetrate that thicker mandibular bone really well, that there's more and more clinicians finding success doing it that way, and being able to do the procedures they have to do. I know that that's something that Stanley Malamed has talked quite a bit about. I've heard him talk about that particular method. So I wonder if that's where it's coming from.
Yeah. It's interesting when you, of course, again, social media is just terrible. We all know that. But it's when you throw out these types of comments and say, I only do this one thing. It goes back to what you're saying, Kelley, of like, you have to have everything in your arsenal and have to be able to deliver everything. Sure, there's a time and a place for this, but generally we could do this, or generally we can do that, and make exceptions.
Well, you want to know, what's the treatment procedure? The doctor you're working for, what are they looking for? How long are they going to take before they get into that room? How long is that kiddo going to be in the room with the assistant? What type of patient do you have? So definitely there's an instance where you can perform infiltration or, get the field or the area with Septicaine, but dependent on the patient, the procedure, the time, that's all consideration that you have to do. And that comes with kind of just more and more experience, of course, of knowing and working with your doctor and knowing what they want, and then patient type as well.
For sure.
I almost wonder if the doctor that asked that question, if he is a general practitioner or if he's a pediatric dentist.
Yeah. Great point.
So expound a little bit more upon that. Like, so for our listener that has doesn't know we all know where you're going, but why would that make a difference, or why would that matter?
Well, I think that in general, it's just a very generalization. I don't want to step on too many toes, but I'm probably going to do it, that general practitioners are kind of thinking in some ways linear with their patients, taking adult concepts to a pediatric level and going, okay, well, we're just going to do this quick little restoration, or it's a primary tooth that's about to fall out, so we don't need to do a lot. When it's something a little bit more complicated, or a pediatric office is going to see a lot more complicated situations, then they're going to be doing a lot more variety of injections and anesthetic procedures. So that's where I was curious, because you don't.
It's a good point. It's a great point.
Yeah.
Okay. Number 5. Here we go. Okay, so this was also it was a ranting comment. I think it was from a doctor. Which, by the way, I probably should have qualified this. I think most of these ones are from doctors. The hygienists, they didn't seem to have as many questions or as many thoughts. And I don't know if it's just because, if we're in school, right? Washington, Oregon specifically. I know Arizona does a really good job too. I know there's lots of states that do a really, really in-depth. I think that's where we're all from. So I think that's what I'm thinking. But anyway, it's robust our education. And so like, there's not really too many times we're going to get kind of like, what do we do in this situation? We know, right? Because we're taught, because we have to, and we take a board and we do all these things. And I know doctors are taught too, but I don't think that they're like lectured as much as we are. Or they're not. Anyways, they just do. They do a lot of learning by doing kind of situation. And so anyway, so a lot of these questions are like, oh, what do I do here? Okay. Anyways, here we go. So they said, when has anyone in the world used Prilocaine? We use lidocaine, articaine, and bupivacaine. And so what are your thoughts on this? Hold on, let me read that again, just because it cracked me up. When has anyone in the world used Prilocaine? Okay, go.
Okay. Well, Prilocaine is, lidocaine and Prilocaine are the two anesthetic drugs you can use that are FDA approved for pregnant individuals. So there is that. Also, Prilocaine does have the $1 to $200,000. Where did that come from? 1 to 200,000 epi.
As in, you're speaking their language now with the money talk.
Yes.
The 1 to 200K epi, and which for our patients who are at a higher ASA level with cardiac compromise, you have to be more cognizant of that. So, in the world where a lot of people at a certain point in time were very concerned about using like articaine for a mandibular block, and you have a patient that is cardiac compromised, using a CNS forte, which is the Prilocaine with 1 to 200,000 epi, would be your drug of choice. So there is a patient for it, but it may not always be there.
Well, it goes back to just being able to have yourself open and using the tools in the toolbox if needed, and not just kind of blindly moving through what you do every day. So knowing that there's options and what's best suited for your patient. So
would it be fair for an office, like if we're trying to help someone like with their ordering, have like a box of it on the shelf? It's usually 2 years expiration date, or whatever the expiration date is for some of these boxes. Just make sure it's not expired. And then just just reviewing that regularly. And if you need it, you need it, kind of a thing.
Yeah.
Absolutely.
Yeah. You want to have options, because if you're in a pinch and you need it and you don't have it, that's not fun either. So yeah.
I noticed that they left off mepivacaine on this list of theirs too. I thought that we used that quite a bit when I was, doing it, but I don't know what they're using over here. Okay. Number 6, from a doctor again. Just saw a patient that will need several fillings, not bombed out, but decay in each quad. I am not very comfortable with children and wonder if I should refer out to specialty. What should I do?
I'll take this one. So dependent on the size of the patient, the extensiveness of the treatment needed, the behavior profile, financial reasons, but talking local anesthetic and safety, typically if you have a small window of time, so say you're doing 2 restorations on the upper right quad and you have on the lower right, you have 1, and you can successfully infiltrate, the lower right and successfully infiltrate the upper right, you can kind of square off that side of the mouth, and the dentist can be in and out of there and do it quickly, and you can be safe about it. So, and then have them come back for the other side or the other half of the mouth. But we always go case by case basis in the practices I've worked in. So you're being safe. You're also making sure the patient has a good experience and that they can handle. You might want to start on one quadrant if they've never had treatment before, see how they do with local. And so if the hygienist is the one delivering local, it's very, very important that you're kind of paving the way of how this visit's going to go. So being very secure, confident, and making that patient comfortable can do a lot for their experience, but also for the doctor treating and, be efficient about what the goals are.
Kelley, can I ask you a follow-up question to that?
Yeah.
So I know that not in every state hygienists can do nitrous.
Right.
But wouldn't you also say that in a case like that, maybe some nitrous oxide for the patient along with the local anesthesia? Yeah.
Yeah, always. If that's an option, health history is indicative of, that being okay. Nitrous oxide is, our secret sauce, if you will, in pediatric dentistry, because, if you're really good about the titration and looking at your patient and making sure that they're comfortable, it can do a lot for their experience and also for the treatment purpose. So yeah, definitely nitrous oxide is very lovely.
As a follow-up to the follow-up question, kind of along the same lines. This wasn't one of the questions that were asked, but I think this is probably maybe something one of our listeners might be thinking about. Dentists have the ability to kind of refer out pediatric patients if they want to, right? So what about us? You're working in a general practice and your doctor's like, yeah, I'll see whoever, I don't really care. Do we have that option as hygienists to be like, look, this is outside of my comfort zone, seeing a pediatric patient? I don't know enough, or are we expected to just suck it up and do it?
I think there's a time where you're expected to suck it up and do it, but also that comes with experience and confidence of being able to stick up for yourself and speak out for what's best for you, and then in turn what's best for the patient. If you don't feel comfortable, you don't have the skill set, maybe you're in a practice, there's another individual that can take over for you, but you definitely want to speak out if it's not going to be an ideal situation.
I can't say anything more than that.
Yeah.
That was perfect, Kelley.
I will tell you though, 9 times out of 10, I will take the whole family. I will take both parents and all their kids, and then the other hygienist can have all the really deep perio and all this other garbage.
Yes.
Like I don't want any of that. They can I'll happily trade and take all the kids. But I'm a big guy, and sometimes those kids they don't like seeing me, so I don't know.